Welcome to this lecture on pharmacodynamics. Today we're going to be having a look at the relationship between drug dose and response. So pharmacodynamics, as you should know, is the effects of a drug on the body, and it is made up, there's a number of different things within pharmacodynamics that we can look at. We can look at the mechanisms of action for drugs. So this is looking at things like what are the targets for drug action, and these include receptors, ion channels, enzymes, carriers. We can look at how the drug acts at the target. So is the drug acting at a receptor, for example, as an agonist, so activating the receptor, or is a drug acting, for example, as an antagonist? An antagonist block the actions of agonists. So mechanisms of action of drugs also encompasses things like, once it's acted at that target, how does the drug produce an action within a cell? Does it cause an opening of an ion channel? Does it cause a triggering of a second messenger cell signaling cascade? Another component of pharmacodynamics is looking at the relationship between drug dose and response. And this is looking at things like graphical representations of increasing concentration of your drug over the effect that it has. And it also encompasses looking at things like toxic versus therapeutic effects of a drug. And today, what we are going to be having a look at here is this aspect, so the relationships between drug dose and response. And we're going to have a look at this graphically, and we're also going to define some terms. So we're going to define some terms such as affinity, efficacy, potency, and partial agonist. So just to get us started thinking about drug dose and response, let's just imagine that you wake up in the morning and you have got a headache and you decide that you are going to take some aspirin to relieve your headache. What dose of aspirin would you take to relieve your headache? Just have a think now. So the correct answer to this is B. You would take between around 300 and 600 milligrams. Now, what do you think would happen if you took 25 to 50 milligrams? If you took that much, you basically would still have your headache. It wouldn't be enough of the drug, it wouldn't be enough of the aspirin to relieve your headache. What would happen, do you think, if you took 5 to 10 grams? If you took 5 to 10 grams, you probably wouldn't die, depending on your weight, unless you were very, very light. But you might be quite sick. You might have nausea, you might have vomiting, you might have some drowsiness. And this, in its very simplest state, is an example of a dose-response curve. You need to take enough of a given dose of drug to have the therapeutic effect that you're looking for. But if you take too much of it, you will then start to see unwanted side effects of it. So this is a very simple dose-response curve. Now, I want to think about what happens when an agonist, so an agonist drug, binds to a receptor. So an agonist is a ligand, and that might be the drug that you're giving, or it could be an endogenous hormone, an endogenous neurotransmitter. So an agonist is a ligand that combines with a receptor to elicit a cellular response. And I've represented that in this diagram here, in this schematic here. And I'll be using this diagram throughout this lecture to illustrate some of the things we will be covering, efficacy, affinity, etc. So what happens is that an agonist binds to the receptor and it forms this agonist-receptor complex. And this idea of an agonist-receptor complex is quite important in pharmacology. So once this complex is formed, it causes an action within the cell that then results in the biological effect. And that's a biological effect that you're interested in. So it might be that you are looking at an anti-asthma drug and you're looking for, so you're looking for bronchodilation. It might be that you're looking for a drug that decreases blood pressure or something like that. But let's go with the asthma example here. So if we think about the drug salbutamol, salbutamol is used to alleviate acute asthma attacks. You take it by inhalation and it binds to the beta-2 adrenoreceptors in the lungs. And there it forms this salbutamol beta-2 adrenoreceptor complex. This causes intracellular actions, one of which is an increase in cyclic AMP, and ultimately causes the effect we're looking for, the therapeutic effect, which is the bronchodilation. So we can measure these dose-response relationships using what's called a graded dose-response curve, or sometimes called a concentration effect curve. There is another type of dose-response curve called a quantile one, which we'll not look at today. Now, a graded dose-response curve measures the response of a particular system. So that might be an individual patient, it could be an individual mouse or monkey, it might be an isolated piece of tissue. So it measures the response of that system against increasing concentrations of your agonist. So an example might be that you have prepared a trachea, so the windpipe from a rabbit, and you give increasing doses of salbutamol to that preparation, and you measure the increasing bronchodilation in response to the increasing doses of the drug. And you would plot it on a graded dose-response curve or on a graded concentration effect curve. So let's have a look at one of these concentration effect curves now. It is a semi-logarithmic plot of agonist concentration on the x-axis against the effect or the response on the y-axis. And it's called semi-logarithmic because one of the axes, the x-axis here, is logarithmic. So the agonist concentration is plotted logarithmically and the effect that is elicited is plotted linearly. And what these curves look like is this sort of typical sigmoidal S-shaped curve that we see quite often in biology. And you see that with increasing doses of the agonist, you get an increasing effect from the system. And what's being represented in this graph here, in this sigmoidal curve, is essentially the agonist and receptor coming together to form a complex, having an intracellular action and causing that effect, so your bronchodilation, for example. I'm just going to say a little bit now about log axes because sometimes some students can find log axes and interpreting them a little bit difficult. So when we're looking at these concentration effect curves, as I said, it is semi-logarithmic, and the reason that we usually plot it logarithmically is because it stretches out that middle section of the graph, which is the area that we're most interested in and will be most interested in, and it makes it easier to read and interpret the results from these curves. So it stretches out the data so we can see that linear section more clearly. And for these concentration effect graphs, when they're plotted logarithmically, we use base to the log 10 logarithms. Now what this means is when we look at the axis, there is a 10-fold increase from one unit to the next. So if we have a look at this 10 micromolar, so 10-fold increase times 10, our next unit here is 10. If we then look from 10, there's a 10-fold increase to the next unit, so that's 10 times 10, we get to 100. And then there's a 10-fold increase from 100 to 1,000. So that's what we're looking at. Now you may in papers see the x-axis written out like this, like 0.001, 0.1, but more likely and more often than not you won't. And part of that is just a space-saving measure on the actual axis on the graph. So more often than not you'll see it plotted as like 10 to the 1, 10 to the 2, 10 to the 3. So 10 to the 1 is 10, 10 to the 2 is 10 times 10, which is 100. 10 to the 3, 10 times 10 times 10, which is 1,000. So just a note on the log axis there. So why do we want to plot these concentration effect curves? Well, when we are thinking about designing and developing drugs, the drug companies or the people who are interested in making drugs need to know a number of different things, because when they're designing drugs, they will, the pharmacologists will develop a whole range of different chemicals that they think will bind to the receptors. But the first thing you really want to know is, well, does it actually bind to the receptor? You're wanting it to target a particular receptor, your one of interest, your beta adrenergic receptors. So number one, you want to know, does it bind to it? Then you want to know if it's an agonist effect you're looking for. Well, does it actually act as an agonist? Does it activate the receptor? And then the third thing you really want to know is, does it activate it efficiently, like as efficiently as possible? You might have one compound that does activate the receptor, but you need to use 10 grams of it in order to activate the receptor, which isn't going to be very useful if you want to have it as an oral medicine. You might have your second compound that activates the receptor using only 50 micromolar, and that's going to be preferable, you know, in terms of administering a medication. So why do we plot concentration effect curves? Well, it allows us to determine some of the things we want to know in terms of, is the drug going to be efficient? So it allows firstly what's called the efficacy to be determined. So the efficacy is the maximal effect a drug can elicit from that system. And different drugs have got different efficacies. So some drugs have got full efficacy and can very easily activate the system, and some drugs have only got partial efficacy, so are not very good at activating the system. These concentration effect curves can also allow us to measure and determine the potency of a drug. And the potency of a drug is the concentration of a drug needed to produce an effect. And we're going to come back to both of these concepts in a minute. But firstly, we are going to have a look at something called affinity. So affinity describes the strength with which a ligand, so your agonist, binds to the receptor. And affinity is the first thing that you're interested in, because if you're developing a drug and you've got all these compounds that you think will bind to the receptor, you really need to know that. Does the drug bind to the receptor? So affinity describes the strength with which the ligand binds to the receptor. And I've broken down the schematic that I had earlier, so we can see the agonist and the receptor coming together to form the complex. But you can see here that I've added a reversible arrow. So this is a reversible process. So there is a desire for the agonist and the receptor to come together. There's an association. But there's also a sort of dissociation. So the agonist-receptor complex can also dissociate. And a high affinity drug has a much greater tendency to bind to the receptor relative to its dissociation from the receptor. So it wants to bind strongly and doesn't dissociate easily. Now, how do we measure affinity? Because we do want to measure affinity. If we've got 10 different compounds and we want to think, well, which one might be a good drug going forward to develop? We're really looking for a drug that's got high affinity. We want it to bind well. And we do that by measuring this thing called the KD value. And the KD is an equilibrium dissociation constant, and it can be measured from a graph. And we can use this in order to calculate a drug's affinity. So as I said, the KD is the equilibrium dissociation constant. And what it is it's the concentration of ligand at which 50% of the available receptors in the system are occupied. Now, I'm showing you a graph here, which looks very similar to the one I showed you earlier when we were looking at concentration effect curves, but this graph is different because the y-axis is different. Along the x-axis, it's the same. We're looking at increasing concentrations of the agonist, but along the y-axis, what we're looking at here is the percentage of receptors that are occupied, and what we're looking at is an agonist-binding curve. Okay. So KD is an intrinsic property of any drug receptor pair. So any drug receptor pair has got a KD value. And there is an inverse relationship between KD and affinity. And I'll say more about this in the next slide. But if we just look at this graph here, you can see we can measure from these agonist binding curves the KD value. So on the y-axis, we've got the percentage of receptors occupied. And if we read the concentration of ligand at which 50% of the receptors are occupied, from the graph, we can go across from 50, if you follow this dotted green line, until it hits the curve. Then you go down to the x-axis, you read off here that this drug receptor pair has got a KD of around 100 millimolar. So that's how you read your KD value. And you can use the reading of the KD value to calculate the affinity or to measure the affinity of a drug. So as I said, KD allows us to compare the affinity of different agonists. So here we've got agonist A, and we've got our sigmoidal receptor binding curve, and here we've got agonist B with our sigmoidal receptor binding curve. And we look at the percent receptors occupied, and we can calculate the KD for both agonist A and agonist B. Now, the lower the KD value, the more easily the agonist binds to the receptor. And so, the lower the KD value, the greater the affinity for the receptor. If we've got an agonist, let's call it agonist D, that can bind to 50% of the receptors at 1 millimolar, and we've got agonist E that binds to the receptors with 100 millimolar, you can see that agonist D has got a higher affinity because it needs a much, much smaller amount in the system in order to occupy 50% of the receptors. I'm just going to pause there just to let you read that slide and make sure you understand it. Okay, so the smaller amount of drug that's needed to occupy 50% of the receptors, the higher affinity. It binds better. I've got a question, I've got a few questions throughout this presentation here, just to let you test yourself and your understanding of that. So I'm going to ask you to quantify the difference in affinity between agonist A and agonist B. Okay, I'm going to reveal the answer now, so pause if you need a minute more. So agonist A has got 100 times more affinity than agonist B. So the first thing that we want to look at is that agonist A has a KD which is much lower than agonist B. So we can see here agonist A occupies 50% of the receptors when only 0.1 micromolar of the agonist is present, whereas agonist B requires 10 micromolars of agonist B in order to cause 50% receptor occupancy. So agonist A has a higher affinity than agonist B, and we can quantify the difference by looking at the x-axis here. So we can see there's a 10-fold difference between the KD of agonist A here, between that 0.1 and 1 is a 10-fold difference, and then there's another 10-fold difference between 1 and 10. So it's 10 times 10, there is a 100-fold difference between these two agonists. I'm going to come back to look now at efficacy and potency. And we're going to have a look now, rather than looking at the binding curves, we're going to have a look at agonist response curves or agonist effect curves. And I've taken the schematic here and I've shown it in a little bit more detail. So we've got our agonist and receptor coming together to form that complex, that's reversible, which then forms an intracellular action that causes your biological effect you're looking at. And the effect that any particular agonist produces is dependent on two things. So firstly, as we've discussed, it's dependent on the drug binding to the receptor in the first place, that's its affinity. But then secondly, it's also dependent on that drug receptor pair then causing a biological effect, causing a biological response. And we can look at this graphically too. So if we have a look at this graph, we're looking again at the agonist concentration on the x-axis, and on the y-axis here we are looking at the effect from the system, so that might be bronchodilation. And from these graphs here we can measure something called EC50, and EC50 is a measure of the potency of a drug. The EC50 is a concentration of ligand is the concentration of ligand which is 50% of the maximal effect that drug can elicit. So if we look here at this drug eliciting near maximal, near 100% effect, we can measure the EC50, this blue dotted line across it from the graph, and then we can measure the potency of that particular drug from this graph. So what is potency? Well, potency, if you look in different textbooks and if you look in different journal articles, it can actually be defined a little bit differently. It can sometimes be thought of as a slightly vague notion, but essentially what potency is it's the amount of drug that's needed to produce a given effect. And potency is dependent on a number of things. So potency is dependent very strongly on the affinity of a drug. So if the drug binds very strongly to the receptor, it generally has high potency. But it's also dependent on the efficacy, which we'll look at in the next slide. And it's also dependent on things like the number of receptors in a system. So if you give a drug into a system that's only got 100 receptors, a particular dose of a drug, the effect that you get from that system is going to be different if you give the same dose of a drug to a system or a tissue preparation that's got 10,000 receptors in it. It's also dependent on things like the efficiency of the stimulus response mechanism. So you could give a particular dose of a drug to a cell line which has only got a small number of cofactors and second messenger molecules, and so the effectiveness of that signal transduction is not going to be massively amplified. You could give the same dose of a drug to a tissue or a cell preparation that's got loads and loads of cofactors, and so when you give that dose of a drug, you get this massive amplification and cell signaling cascade. So potency is dependent on a lot of different things, but generally, as a rule of thumb, you can say that agonists that have got high potency tend to have high affinity. So if your drug binds well to the receptor, it does tend to have high potency. And sometimes you do see textbooks and journal articles confusing potency and affinity, but they are different things. So let's have a think about EC50 values to measure potency. Looking at this graph here. So here we've got agonist A that causes, and you can measure your EC50, your potency across from this graph here, and to measure agonist A's EC50. And agonist B will have its own EC50, which again you can measure from the graph. And very much, the principle is exactly the same as for the KD. Very much it is that the lower the EC50 value, the less drug is needed to produce an effect. So the lower the EC50 value of a drug, the greater the potency is. And I'm going to test you on this a little bit later. Okay. So that's potency. Well, what is efficacy? So when an agonist binds to the receptor, this induces a conformational change in the receptor that sets off a biochemical sort of chain of events and action within the cell. So that might be, for example, the opening of an ion channel. It might be the triggering of a G protein coupled cascade of intracellular sort of signaling events. And basically the agonist receptor complex, and this is called the two receptor theory or two-state theory. The agonist receptor complex can exist in two states. So it can exist in an inactivated and unactivated state, and that's when the agonist and the receptor have joined, but there's been no conformational change, there's been no opening up of the ion channel, for example, there's been no sort of triggering of the G protein cascade, or what I'm going to call the AR star, which is when the receptor is activated, it has undergone this conformational change. And if we look at that on this diagram, we can see that the binding of our agonist and our receptor to form the complex, that's governed by affinity. So the binding of the agonist and receptor complex is affinity. And then the ability of the agonist receptor complex to then activate and cause the actions and cause the cellular effects is governed by efficacy. So efficacy describes the ability of the agonist to activate the receptor. So it's the ability of the agonist to sort of invoke this action, the cellular action. And efficacy refers to the maximal effect an agonist can produce. I've got a couple of slides looking at this now, efficacy. So there are two different types of agonists which are distinguished according to their efficacy. We can get a full agonist, and the majority of drugs that we use are full agonists. And these agonists have got high efficacy. So these are agonists which are likely to have a high maximal effect. And full agonists can often produce a maximal response from the system, even when they're only binding to a small proportion of the available receptors. So full agonists may only bind to 5 to 10% of receptors in the system, but you can still get that maximal effect, that maximal bronchodilation is the example I have been given. This is in contrast to a partial agonist. And a partial agonist is an agonist that once it's bound to the receptor, it is not as good at causing that conformational change. It's not as good as activating the receptor. And these are drugs that, even when you give really, really high concentrations of them, they're never able to elicit the full effects that would be capable with another drug within that system. And for partial agonists, you might have the partial agonist actually binding to every single receptor within the system, but it still can't cause that maximal bronchodilation, for example. So I've just got a few slides testing your understanding of some of those concepts now. So which two of these drugs are partial agonists? I'm going to reveal the answer now. So they are B and D. They're partial agonists because they don't reach the maximal effect within that system. Okay. Is drug A or drug C most potent? I'm going to reveal the answer now, so pause it if you want a little bit more time. So drug A is more potent because causes 50% maximal effect at a lower concentration of drug than dose C does. So if we look at across this blue line here, we're looking at EC50s, we see that drug A has got a lower EC50 than drug C. Therefore, drug A is more potent than drug C. So true or false, drug B has greater efficacy than drug A. Does drug B have greater efficacy than drug A? So this one is true because B is able to produce a greater maximal response than A. B has got a higher Emax than A, so it has got a higher efficacy. Remember, efficacy relates to Emax, the maximal response that a drug can produce. So at this point, what I would like you to do now is to look back through the presentation, or think back through the presentation, look back through any notes you have made. And I would like you to come up with your own key points from this lecture. From an educational perspective and from a learning and a cognitive perspective, it is much, much more efficient for you to think about and to digest this lecture and to think of what are the key points that you've learned and write them down in your own words than it is for you to just listen to my key point summary slide, which I'm going to give you in a minute. So what I would encourage you to do now is to pause this, to have a look at any textbooks you have, to go and show you some of my key points from this lecture, but do pause the presentation and take a little bit of time to do this. It is probably one of the best things you can do from an educational thing at the end of any sort of learning resource is put it into your own words. Okay, so some of my key points are that the affinity of an agonist is the likelihood that it will bind to and form a stable complex with the receptor. It's that binding, the likelihood of stable agonist-receptor binding. The potency of different agonists can be compared by assessing their EC50 values. The lower the EC50 value, the higher the potency. So I haven't written it in the key points, but this is similar is true for if we're looking at affinity. So if we're looking at affinity, you can measure the KD value, the dissociation constant, and the lower the KD value, the higher the affinity. Efficacy describes the ability of an agonist once bound to activate the receptor and cause an effect. Full agonists have got high efficacy and they can produce maximal responses from the system, whereas partial agonists have got lower efficacy and cannot produce a maximal response in the system. So thank you very much for listening to this session.